Among various available regional analgesia options for knee surgeries and below knee surgeries, the goal is to choose motor sparing, opioid sparing, and procedure specific modalities. For that, we should know all the approaches of various types of knee joint surgeries along with their innervations. And we also should know about the pain generators before and after surgery to plan for procedure specific regional analgesia technique. Any surgery is correction of existing pathology and creation of iatrogenic pathology, that is surgical dissection. This is a schematic representation of the knee joint where the C shapes you can see intra-articularly. These are meniscus, then cruciates also visible in the form of X alphabet. Then these are the anterior capsule, anterior musculature, posterior musculature, and this anterior skin and subcutaneous tissue, posterior skin and subcutaneous tissue. Similarly, this area colored by the yellow color is actually anterior innervation, whereas the blue color represent the posterior innervation. So if you see, the posterior innervation also include the intra-articular component along with the posterior capsule. So if you consider the pre-operative total knee replacement knee joint, so pre-operatively such patient is having more pain inside the knee joint because of the pathology involving the articular cartilage, that is osteoarthritis of the knee joint, whereas the extra-articular component, the pain generation is relatively less. When the same patient when the same patient undergoes total knee replacement surgery, all the intra-articular pain generators are excised and replaced by the non-neural and non-vascular metallic implant, where the richly innervated anterior capsule is also getting excised. So whatever the pain generation which was there before during the surgery, it is getting removed. So most of the pain generation will happen into the surgical dissection area which was relatively healthy before the surgery. So most of the time the post-operative pain generation of the anterior component is more than the posterior component. Similarly, for orthoscopic surgery, if you see, the involved pathology is intra-articular, so the pain before surgery is intra-articular. Even after surgery, the whole surgical dissection takes place intra-articularly. The pain generation will remain inside the knee joint. Whereas extra-articular surgical dissection, which is nothing but the port insertion side, the pain generation from that side is negligible. So block involving mainly the posterior component should be given priorities for the orthoscopic knee surgeries. Most importantly, we should know the analgesic coverage of each regional analgesia option to use them as per analgesic requirement. In first figure, femoral triangle block will involve the saphenous nerve and nerve to vastus medalis. So it will cover the anterior medial aspect of the knee joint, but it will not cover intra-articular component of the knee joint. Adductor canal block, by covering the saphenous nerve directly, it will cover saphenous nerve territory, as well as by distal spread into the popliteal plexus, it covers the intra-articular component. Dual subarterial block covers anterior medial knee by its first injection, and second injection covers the intra-articular component of the knee pain. So it is having procedure specific coverage for the medial approaches of the total knee replacement surgery. IPAC blocks mainly targets the popliteal plexus, so it will cover only the intra-articular pain. Local infiltration analgesia is having wide coverage, but its coverage depends on the surgeon choice of specific sites of injection. And also the duration of the analgesia is the problem with the local infiltration analgesia, which is not more than 12 to 18 hours. High pack block covers all the innervation below the knee joint, so it involves the sciatic nerve component as well as femoral nerve components. To conclude, femoral triangle block mainly covers the anterior knee pain, whereas adductor canal block because of the coverage in the popliteal plexus. It covers posterior knee pain than anterior knee pain. Dual subsartorial block is described as a procedure-specific block for total knee replacement surgery with the medial approaches that covers both anterior and posterior component of the knee pain. IPAC block, by covering the popliteal plexus, can be useful for the posterior knee pain. High-pack block and 4-in-1 block, these are described as a procedure-specific and motor-sparing block for below knee surgery, as they cover all the innervation below the knee joint by blocking sciatic nerve and saphenous nerve. The motor sparing effect of the CAPS blocks depends on the concentration of the local anesthetic used. The efficacy of the local infiltration analgesia depends on the various sites of the administration by the surgeon. Also, the duration of analgesia is always a problem. It is not more than 12 to 18 hours. So there is always chance of breakthrough pain, and it is also associated with infection, chondrotoxicity and redo surgeries. So basically, we just need to maintain the balance between mobility and pain control by providing excellent analgesia.